Hello and welcome to another episode of Making Vestibular Visible and our Facebook Live video education series from Vestibular Disorders Association. I'm your host, Dr. Kathleen Stross, former president of the VeDA Board of Directors and a member of VeDA's Medical Advisory Board. I'm also a private practitioner in vestibular health in Houston, Texas. Today, I have the pleasure of sitting with A Goebel. He is the chair of VeDA's Medical and Scientific Advisory Board and the former director of the Vestibular and Oculomotor Laboratory at the Department of Otolaryngology, Head and Neck Surgery at Washington University School of Medicine in St. Louis, Missouri. Welcome, Dr. Goebel.
Thank you.
Today, we're going to be following up on the conversation that we had earlier with an expert panel of physicians and rehab specialists about the field of vestibular medicine, vestibular disorders, their evaluation, and the treatment. And when we weren't able to have you join us on that day, I thought it'd be really nice to have a sit-down chat with you about that conversation and about some things maybe we should explore a little bit further. But before we jump into that, I'd like you to tell the audience about yourself and how you came to the position of being the new chair of the Medical Advisory Board at VeDA and about your practice.
Yeah, thank you. Thank you, Kathleen. So I started this journey way back in medical school and then also in my residency. I had a faculty member who taught me vestibular medicine, Malcolm Stroud. He was a Brit in our department, and I just fell in love with it. Finished my residency, took a faculty position right away, and continued my work. It used to be called the Vestibular and Oculomotor Laboratory. Now it's called the Dizziness and Balance Center over the years, and it's grown. We started with just a caloric irrigator and a drain in the floor and a strip chart recorder, and now it's grown to, many, many tests, as you might know. And so that's 35 years of seeing balance and dizzy patients. And I think my career has grown a lot. My insights have grown a lot. And I retired from clinical practice in 2020, but I continued my research. I'm on government grants, consulting, and I'm publishing, and I'm still lecturing around the world. So this is still a passion. And when I was asked, would you chair the Medical Advisory Board at VeDA, I said, sure, it'd be my pleasure. I have some thoughts about where we can go with VeDA and things that maybe we on the Medical Advisory Board could do not only for patients, but also for each other. And so out of those early conversations a few months ago grew the Ask the Expert videos, which have come out, so that we can take a multidisciplinary group on any given session, present questions, and get input from many different angles. So that's where I'm at.
That's great. Well, no, we missed you on the last panel discussion, but I know that we're going to get to learn more about your insights and experiences during this conversation. We've never spoken to our vestibular audience about the Medical and Advisory Board with VeDA. Would you mind just sharing a little bit more about what you see its function to be and what you hope for it to accomplish? Because I'd like this to be a platform where we continue a conversation about where are we going as an organization and how that Medical and Scientific Advisory Board might play a role in that.
Yeah, sure. So without being political, I'll use the phrase, it takes a village. Mm. And it really does. It taking care of patients with dizziness and balance disorders is truly multidisciplinary. And that's why the Medical Advisory Board is represented by almost every medical specialty and allied health specialist that you can think of in order to serve patients better and in also order to cross-fertilize and educate each other. So I see the Medical Advisory Board in multiple ways. One is if you publish something like a newsletter, Medical Advisory Board can make sure that it's accurate, that it's true. The Medical Advisory Board is a source of those publications themselves. So, they can input into those publications and into the Ask the Expert. I see it perhaps going even further to try to foster the education of us as specialists, not only within our own bullseyes, but also within the team. Because I in my practice would never attempt to do what the physical therapist does, or the audiologist does, or the neurologist does. My bullseye was in neurotology. However, I understand what they do, and I understand how to work together as a team. And so the most important thing I think the medical advisory board could do is to foster this multidisciplinary team concept, that no one of us can really claim to take care of the variety of dizziness and balance disorders that patients have. And so the more that we understand that, and across our nation, across the country, build these teams. And we have ways to do that now. We don't have to just all be in the same city anymore. We have telehealth.
Right.
We have ways to create networks, just like we're doing right now, to be able to discuss patients, bounce ideas off of each other, make sure that we're giving the appropriate care. So I think the medical advisory board is multidisciplinary, and it is a village, and it takes a village in order to take care of everybody.
That's great. I look forward to seeing that develop and seeing more of the representatives of the medical advisory board forward facing to the vestibular population across the world. We are fortunate to have many multidisciplinary centers. And one of the conversations or comments that came out of the last chat was that while it's really important to have all the different disciplines in the multidisciplinary team, it's not required for a vestibular patient to see all of them. And that's an important concept, I think, for people to hear. And that leads us to the idea of how a patient enters the healthcare system and what comments you have about patients' initial experience in the doctor's office or emergency department and the approach to managing the acute vestibular patient.
Yeah. So the ideal world would be that patient goes to a healthcare provider with their dizziness, and whether it's acute or chronic, and that healthcare provider says, "Oh, I know what's wrong with you," and would be right. That's the end of story. There's your diagnosis, and then you move on to treatment. Well, that's not reality. And reality is that depending upon where you go and who you see, what specialty you see, or what person within that specialty, you may end up getting a variety of opinions about what's wrong with you. So one of the first things that we're trying to do is to sharpen the ability of all of us to give an appropriate diagnosis, or at least an appropriate differential diagnosis. It means, well, what's the most likely things that are happening? And so on the intake, and many of the intake comes from the internal medicine doctor, the family doctor, perhaps they end up in the emergency room. So the intake isn't really to a vestibular specialist at first. It's out in the community to educate the community that what's really important in the initial evaluation, particularly of the acutely dizzy patient, and what are you looking for? You know, fortunately, if you've got 100 dizzy patients who are sick, nausea, and vomiting, well, 95% of them are going to have an inner ear problem, or a eighth nerve problem to the inner ear that could be managed over time, is not a medical emergency, and that can be treated symptomatically and then managed as an outpatient. But there's 5 to 10% that truly need to be identified. And so when you're talking about the acute dizzy patient, it behooves all of us to realize that within that 90% that are going to do fine, there's 5 to 10% that need further treatment. And most of those, we're talking about stroke. Most of those are vascular events to the brain, and not just the brain, but the brain stem. And the brain stem stroke is a devastating event. And to misdiagnose a brainstem stroke as peripheral dizziness is truly a disservice, and it's a disaster. So there's this group of acute dizzy patients that you need to make sure you're not dealing with a time bomb.
Mm.
And
You're talking about a brainstem stroke. Share with them I think it can be missed because it doesn't look like other strokes where you lose one side or you lose your speech or you lose. I mean, how does it present differently, and why would a brainstem stroke be missed as opposed to another area of stroke?
So when we think of stroke, we think of I can't move my arm or I can't move my leg or my face is drooping. And many of those strokes happen higher up in the brain, in the cortex, so-called motor cortex. And they're I don't want to say they're obvious, but they're more obvious because they have those signs. When the strokes are in the brainstem, depending upon how big the stroke is, if it's a small stroke and it hits the balance network, then its presenting symptoms are primarily dizziness, imbalance, nausea, and vomiting. And that looks a lot like an inner ear problem. Now, if the stroke in the brainstem is bigger, now you're still going to have a weak arm and a weak leg and a weak face, and it becomes more obvious. But some of those brainstem strokes don't present, at least initially, with the stroke findings that you might expect. And that's why they hide within the dizzy patient that's really sick in the emergency room. Is it really a stroke, or is this your inner ear? So that's the dilemma.
Mm-hmm. Are there certain demographics or certain questions you could ask to identify a population that's more likely to fall into that 5% category? Is there age, gender, other conditions, premorbid or comorbidities?
Yeah, I give a lecture talking about acute vestibular syndrome, and I say if you're 65 years old and you're a male and you're overweight or you have high blood pressure or your lipids are off or you're diabetic, I mean, those are all tick risk factors.
Mm-hmm.
And the emergency room is going to say, oh, look at this. Okay, you're falling into a higher risk category. It's something to consider, but I think it's probably most important is for the emergency room doctor, what are they seeing?
Mm-hmm.
So you might have diabetes and you might have high blood pressure and still have an inner ear problem, right? So it doesn't mean that you're having a stroke when you're having this severe vertigo, but it does raise their antenna a little bit when you come in and you have these demographic risk factors. But it's really critical as to what are they seeing when they look at you that they feel this could be a stroke.
For the person out there who's having symptoms or remember when their symptoms came on, how would you tell them, what would you tell them is the most important way to give them a sense of calm that they didn't have a stroke? What would be a way that they could feel like, oh, well, we ruled that out?
It's dicey because if you didn't get it evaluated, I hate to tell a patient, oh, because you had, these, or you didn't have these symptoms, don't worry about it. I think all acute vestibular crises, I'll call it acute vestibular syndrome, that needs to be looked at. Mm-hmm. Now, when you look back at it, okay, and you look back and see, okay, what features did you have or didn't you have? One of the features of a stroke is the absolute inability to stand unassisted. I mean, if during your dizzy spell, you absolutely couldn't stand, and your spouse or your caregiver or your children or whoever, the ambulance driver, they had to literally pick you up, put you on the gurney, and there's no way if you tried to stand that you could stand unassisted. Whereas most peripheral vestibular patients don't like to stand, but they can. So
that's a really important, very clear observation that I think people can take home and say, if I see my mom and she's having this acute vestibular attack, not that you're not going to provide them with emergency care, you are, but when you start looking at your fears, you're saying the inability to stand.
Yeah, the inability
really raises the level of concern for anyone of any age.
Yes, it does, and that's very easy for a non-medical person to see. Is that, oh, you can't stand up. I mean, this feeling that you're being pushed side to side or front to back is with brainstem disease is just unforgivable. You just can't overcome it. Whereas the imbalance and the sensation of tilt that you get with the inner ear you don't like to stand, but for a few seconds you can do it. Okay, so I think that's key. And then if you just start adding in other features, I'm dizzy plus. What's the plus? Okay, I'm dizzy plus my arm is weak. I'm dizzy plus my face is drooping or it's tingling on one side. Okay, I'm dizzy plus I'm having trouble forming my words. I'm dizzy plus I'm just having a little bit of problem swallowing. I mean, these are all dizzy plus. And once you go into that arena, that needs to be evaluated immediately.
I like that a lot. You saying dizzy plus. In our last Ask the Expert panel, there was a conversation about we should do away with the word dizziness altogether. And you're saying, no, we need that word. And then I would say go further and say, is it movement, or do you feel like you're moving, or the room is moving, or is it just lightheaded? I would differentiate. Throw away the word dizzy maybe in lieu of other words that are more descriptive. But in addition to that feeling in the head, what's going on? Is it the body? Is it more head symptoms? And does it point you to a neurological problem in the brain? And I think that's a great.
Well, in my book, dizziness is the broadest term you can have. About what's the feeling in your head, and then you can whittle down from there. And sometimes if you're really, really sick and it's an acute event, you can't differentiate. I noticed that one of the neurologists on our medical advisory board is very keen that it's hard for an acute, sick, dizzy patient to go any further than just to say, I just don't feel good. Okay. But the chronic dizzy patient or the recurrent dizzy patient in your office, I think you can go further. And so I think it's a valid question. Say, what do you mean when you say that I'm dizzy? Does the room swim? Does the room spin? There's still value in that. There's still value in the characteristic of the sensation. I wouldn't hang your hat completely on it, but as an inner ear doctor for 35 years, and I'm usually seeing patients not in the acute setting, but in the recurrent or chronic setting, when they come into my office and I ask them, are your attacks sensations of the room spinning? They, oh yes, doctor. I look at the room and it's moving. I feel much better that I'm going to find something as I go forward in my exam or my testing that points to the vestibular pathways. Now, it might be central, but most of the time it's peripheral if it's recurrent, okay, and chronic and recurrent. Whereas in the acute setting, I do agree. It's sometimes patients they're so sick, they just can't come up with the words.
Well, and that's why we have to learn how to question them and how to help them, guide them through being able to explain what they're experiencing better. Another comment was about, if we just get the patient to tell us, to describe what their situation is better. Well, again, when you're feeling pretty crummy, sometimes that's hard to do. So our line of questioning is really important. I know for me, I even find once I get to get past, get the patient comfortable talking about themselves, I want to know, are the symptoms from the neck up or are there symptoms from the head down? Because sometimes patients say they're dizzy when they really are having disequilibrium and balance problems in their body or their legs. So, I think some people assume dizzy means the head, but I'm always have to designate, is this your head or your body? Yeah. And that helps.
We put 2 papers in the literature looking at the power of history to diagnose 3 peripheral diseases. Actually, 2 peripheral diseases and 1 central for migraine, vestibular migraine. BPPD, Meniere's disease, and migraine were really quite, by history, the history pointed to these diseases roughly 75 to 80% of the time accurately. Okay, that's even before you did any kind of testing or examination. So there is power in the history. There's significant power in the history, and it's not a matter of just give up on it. It's important to dig, but it's also important to know what's important in the history and what's not. And to me, what's important in the history in my patients as outpatients would be the quality of what you're feeling, the timing of what you're feeling, how long does it last, and what are your triggers, and then what else happens. So
That's right.
those are the four. And if I can get through that, that's giving me a pretty good idea where to look to see if I can find out what the disease is.
In the last Ask the Experts panel, we talked about the importance of diagnosis, or sometimes the fact that the search for a diagnosis can delay rehabilitation or treatment or cause confusion with the patient. Would you like to weigh in on your perspective on the value of a diagnosis and how a person with a vestibular problem might understand when it's absolutely necessary and when we might do shift to symptom management versus diagnostic specific therapy?
Yeah, well, now you're touching on a hot button for me.
Well, that's okay. You're on the hot seat.
Yeah. Proper medical care begins with an accurate diagnosis. End of statement. Now, I know it's hard, and I know it's sometimes onerous to get that, but that does not absolve the medical care community from trying to make a diagnosis. And so shifting to symptom control and blowing right by the diagnostic process would be a disservice to the patients. And I've worked a lot in the United Kingdom and helped them build their multidisciplinary balance centers. And I still lecture every year at the University of Leicester, which is probably the poster child of the integrated balance in the UK. The National Health Service tried to get balance care pushed down a level to lower level providers and just take care of them. Don't worry about the diagnosis, just take care of them. That was a miserable failure. It's a miserable failure. You're going to sit on some people that really would have been better. No, it's not Meniere's disease, it's migraine. Okay. No, it's not vestibular neuritis, that was a stroke. And so the necessity to try to make an accurate diagnosis and a medical diagnosis. I see many patients come in and they say, well, what was your diagnosis? Vertigo. Vertigo is not a diagnosis. Vertigo is
still
a descriptor.
happens.
Yeah, it's a descriptor. Dizziness, that's a descriptor. That's a term. That doesn't say, well, what caused it? And so I'm starting with the whole process that the best care for a balanced patient is the best diagnosis, most accurate diagnosis that they can get. Now, that doesn't stop you from treating them along the way while you're doing that. But I'm not for giving up on it. I'm not for giving up on it, because once you do that, your mind turns off about trying to find out what's wrong. And then you end up over here getting these therapies and getting things that really may or may not be working, but you really don't know what's happening, right? It's like giving insulin when you don't know you're diabetic. Or salt restriction when you don't know if you're hypertensive. So I think a good treatment begins with an accurate diagnosis, and I recognize the problem in the dizzy patient of getting it. I understand that, and we're working on it. We're working on educating.
But you are agreeing though that while you're working on that, you are initiating some treatments that may manage the situation or attempting to try some things. I mean, you are saying that, right? You don't withhold treatment. So I think that's the important thing is while you're committed to a diagnosis, you aren't withholding treatment until you have settled on one.
Oh, no, that wouldn't be right. That wouldn't be right, because many times it's a process of evolution.
Yeah.
Of walking down the way and doing it. So the plan has always been, when a patient left my office, this is what I think you have. This is the treatment that we're going to start. These are the tests we're going to do. And then I'm going to follow you back in a month or 2 months to see whether or not we have progressed correctly. And a lot of times, Kathleen, the treatments that I have started verify that I was right with the diagnosis.
That's key. And that is why, actually, as I have had the opportunity to discuss this with multiple people, I think that everybody really thinks the same for the most part, because we don't withhold treatment while we're waiting for a diagnosis, but we recognize the value of taking steps closer towards an accurate diagnosis each time we engage with the patient.
Right.
And we do trial and error for things. And sometimes the diagnosis is arrived at when we learn what treatment was effective.
Right.
So just for the audience to understand that, you don't withhold treatment and therapy. You want to be taking steps towards a further understanding of an accurate diagnosis with every engagement with your healthcare professional. You're going to be trying something, and that gives them information to help them narrow it down. And the most important thing, and I know it's obvious, but I want to just say it again, the important thing in the beginning with the acute patient is to rule out things that require immediate and definitive therapy, intervention, surgery, treatment, and whatever to sustain life and to minimize catastrophic damage and disability. So, I mean, that has to happen first, ruling out these things. And then when you remain engaged with your professional to find out, well, what is this? It's not a stroke. It's not a mass. It's not these things. What is it then? I'm still symptomatic. It's post-acute, meaning it wasn't an infection that's just going to go away and get better and recover. Like you said, is a lot of those patients with just a kind of probably viral or bacterial situation that will resolve on its own. Then when they move into the chronic situation, we begin offering therapies and treatments to get closer to what would be an accurate.
Yeah, and I think that even the best diagnostician, as they follow a patient, will either sharpen their diagnosis, confirm their diagnosis, or change their diagnosis. And I think it's unfair for a dizzy patient to look at a doctor and to hit the bullseye right on the first visit. I mean, just wow! It's like Mr. Wizard. It's like wow. You had this crystal ball, and you looked right in the crystal ball and said, that's what you have. So sometimes when even the best of balanced medicine specialists look at you, they have in the back of their mind, here's 2 or 3 things I'm thinking of. Let's follow this path. And sometimes it takes a couple of return visits to sharpen the diagnosis until you say, yeah, I really think, for instance, this is Meniere's disease. It's not migraine. Or this is migraine. It's not Meniere's disease. Or this is recurrent vestibular neuritis, again and again. Or maybe this is some other disease process causing recurrent vertigo. So there are times when even the best of the practitioners will adjust their diagnosis. But that's not a failure. That's a process.
This is really, really important to share because we want to manage the expectations of people out there seeking the best care in the world or the best advice. And you're saying that it is to be expected that there are 2 or 3 things that someone will arrive at, and that's normal or typical. That's typical. That's to be expected, and then sharpen the diagnosis. Right. Or change it.
Right. And I think it's fair when I see patients, a new patient, I say, well, this is in my mind. Again, it goes back to the word differential diagnosis. It's not a diagnosis. It's the range of things that I think might be happening. And I say, well, on my first pass seeing you, I'm going to put this as 1, 2, 3, but there's still all 3 things on the table. So we're going to go at this as if it's number 1. Okay. And I'm going to see you back as to whatever I started for you and whatever testing I'm getting. And then I say, well, I might flip number 2 up to number 1, depending upon how this progresses. Okay. So I beg the balanced patients to just be a little bit patient with their vestibular intake specialists. They're looking for a good medical diagnosis. Medical diagnosis is critical, but just be a little bit patient as they're progressing towards that.
That's a really important message. And I think that this is a good focus of our conversation today, because even among these online groups, there are people who seem to receive a diagnosis once they do, and they're happy to at least have one, but then they wear it on their chest that they identify as this. This is what I am, rather than I'm a vestibular patient or a person with a vestibular disorder. They cling to that one diagnosis. Then if they see another doctor, they might get a different one. And I think what you're alluding to is that all healthcare professionals will have a list of differential diagnosis that it may be. So can you speak to, do I have multiple things, or do I have one thing, or, how do we know about comorbidities, or do I have more than one thing going on, or do I just have multiple doctors telling me multiple things?
Yeah, I think the way to approach this is that you have one major process causing your symptoms. And it doesn't preclude that you might have something else.
But most of the time?
But a good deal of the time I'm looking for the key thing that's driving your symptoms. And I'm not ready to say, well, I think you have this plus this plus this plus this.
Mhm.
And that gives you sort of a hodgepodge of diagnoses. I will say that within the balanced world, and this has happened within the last 15 to 20 years, one confounder about could you have something else is the onset of vestibular migraine. Vestibular migraine
Yes.
has just put an electric shock through the balance world because migraine is so prevalent. Migraine is so prevalent
Mhm.
in the population that to have migraine, meaning headache, migraine cephalgia, and then possibly having vestibular migraine, which is the dizzy part of migraine, and then having an inner ear problem, that's possible. So I think the one caveat I'll have to say with having more than one diagnosis is we've got our eye out now for the primary cause, BPPV, Meniere's disease, vestibular neuritis, but also are you a migrainer? And
Mhm.
that was a brand new question that went into my repertoire about 20 years ago. Are you a migrainer? Were you a motion sensitive child? Could you read a book in the car?
Mhm. Mhm.
Okay, did you have splitting headaches with your menstrual periods, or did you develop some unexplained dizziness in your 20s? Just the whole looking for the smoking gun of migraine. So if you have two things going on in my practice, one of them was migraine, and the other one,
Mhm.
and then the other one was another process. So migraine plus BPPV, migraine plus Meniere's, migraine plus superior canal, migraine plus neuritis. Okay, so that's the one instance where you could have two things going on, and then you got to decide which one's driving most of the symptoms. Okay, is it the inner ear problem, or is it the migraine? And sometimes it's hard to differentiate because the spells are really close together.
That's an interesting conversation. It's a chicken and egg conversation of which one drives or which one's first. Because even in my training many years ago, it was migraineurs were more likely to have lots of things, whether it was TMJ, fibromyalgia, chronic fatigue. Now we say vestibular BPPV. We've got all these correlations that if you have migraine headaches, you're more likely. There's just a correlation between migraine and many, many other things, it seems to me. And so I think that there's a lot to be explored as we continue looking at the causes of migraines, but also what does that predispose a patient to have additionally. And maybe it is how they process their pain, how they process discomfort, how they manage a feeling of wellness versus not being well.
Yeah, well, you mentioned something very important. Are these two conditions that coexist in a patient, or is there a cause and effect?
Mhm.
In other words, is one causing the other? And sometimes, in migraine, we're not sure,
Right.
right? And the migraine brain is a brain just waiting to be stimulated. And once it's stimulated, it goes in many different directions, whether it's a headache or whether it's visual disturbances or whether it's
Yes.
vertigo or whatever. So the migraine brain, and again, in my patients who had migraine plus some other problem, I had to get the migraine under control first.
Mhm.
I mean, I had to so-called turn the burner down.
Because it flavored, didn't it? It had an impact on their experience with any other illness or physical challenge.
Right.
Because
Well, so
and the turning the burner down, and
yeah.
yes, is a great way of putting it.
So the dizzy patient without migraine may feel their symptoms are here. The dizzy patient with migraine feels their symptoms is way off the screen, right? And so if you can turn the burner down, they're still having their dizzy problem from their inner ear, but the burner is turned down, the brain is turned down. And, the new medications that have come out are going to turn out to be very, very helpful, with calcitonin gene-related peptide inhibitors. That they're very helpful for headaches. And I think as the studies go on, you're going to find that it's going to be helpful also for the vertigo patient.
Well, and this does segue into the idea of anxiety being a huge overlay and a challenge to managing some of these patients who have these chronic symptoms. I know sometimes that if the anxiety is so strong, it makes vestibular rehabilitation nearly impossible. You almost have to, like you said, turn the burner down, cool everything off a little bit, bring the nervous system to a more calm level where it can rest and restore and repair, get them out of fight, flight, or freeze, and out of this panic and anxiety and headache and everything, where they become hypervigilant. I mean, that's another word that I think identifies some of these patients who are stuck in this chronic symptom pattern.
Right. Yeah, that's absolutely right. And if you've ever been dizzy, I mean, really dizzy, it will generate anxiety because you no longer can maneuver in the world that you normally just automatically maneuvered within. So that's what's called trait anxiety. You developed anxiety due to something. But then there are patients who have state anxiety. State anxiety existed well before anything happened. Their brain is wired to be anxious. And they're just the person with an anxiety disorder, just their brain looks for something that is causing symptoms, right? And once that symptom is controlled, their brain goes to something else to find the symptoms. So, and sometimes in the chronically dizzy patient, the acute event is over, and they were in this process of adapting, but then they froze, and the adaptation process just stalled. And that's where the brain kicked in and said, wow, what's wrong with me? I'm not getting any better. And then this sort of hypervigilant process, visual dependence process where visual motion just, you can't tell who's moving, and you can't maneuver within your world, and you're dizzy way more than you would have expected from the acute event. That's a patient who has not adapted correctly. And the initial adaptation was correct. I mean, when you have an inner ear problem, you start relying on vision. But if you continue to rely on vision when the acute problem is over, now you're into a maladaptive state. That should have stopped. You should have reverted back to your normal use of senses, but you're not. But you didn't.
Do you relate that maladaptation to PPPD?
Well, that's what I'm talking about. I just didn't use the 4 letters.
Ah,
Yeah.
okay.
And everybody out there has got to understand that PPPD or triple PD, whatever you want to call it, it's an attempt by the balance world to bring the concept together and get rid of all the other alphabet soup that's out there. And, it's not really a tight diagnosis. It's almost a syndrome. And it's been called many things in the past: visual vertigo, chronic subjective dizziness, phobic postural vertigo. It's been called a lot of things. So the balance world, through a society called the Barony Society, which is very big worldwide, just wanted to bring it together under one umbrella. And what they're saying is something happened to you. Now, it doesn't have to be a vestibular event. It could be lots of things. It could be stress, post-traumatic stress syndrome, whatever. But let's talk about the vestibular patient. You had a vestibular event. It's over. You started to adapt, you stalled, and now you're frozen in space. You just aren't getting any better. And you're 3 to 6 months out. You're dizzy half of the days of the month. You're better when you're perfectly still. You don't like to move your head. You don't like busy visual surrounds. Okay. So that's a maladaptive state. And that's what triple VPD is describing. Okay. Because it's persistent postural perceptual dizziness. Okay. And we're actually have studies in the literature now. I'm working with my colleagues in the UK to try to identify traits in patients who are prone to develop triple PD if they get an injury. Because we believe that if you are one of those prone individuals that are primed to go into this, and then you get a vestibular event, if we intervene earlier.
Yes.
If we intervene earlier and we give you the appropriate habituation therapy, we give you the appropriate medical treatment, we give you the appropriate cognitive behavioral therapy, well before you went into this maladaptive state, maybe we could keep you from going into it.
That is the hope.
That is a hope. So we're not there yet, but that's with the studies. We've got ongoing study in the UK right now, got 2 papers in the literature and 1 under review.
That's the important hope, and that's what I want people to hear, that triple PD or PPPD, persistent perceptual postural disease, is not a new disorder. It's a new name for something we've been finding for a long time. As long as there have been vestibular disorders and dizziness symptoms, there have been those who have this maladaptive syndrome, like you're referring to it as a syndrome, where the brain did the best it could to recover, and somehow the adaptation did not restore this balance or homeostasis or healthy state to the body. And I think that is a brain consideration, and perhaps there are potentials for new medications and new therapies or combined multidisciplinary therapies,
right,
including the psychological and psychiatric fields, to reduce the number of people who transition into triple PD.
Yeah, I think this hypervigilant state, you're sort of over monitoring your body.
Yeah.
You all of a sudden are monitoring your breathing, and you're monitoring your heartbeat, and you're monitoring your body sway. To you, that fraction of a degree of body sway seems like it's big, and yet nobody else sees it. But to you, you're so attuned to what your body's doing that you take a very small stimulus and it feels that big.
Yeah, it does. I ask people, I say, if I saw you, would I know you were off balance? And so because you do want to know, are other people noticing you, or are you feeling things in an amplified way that cause you discomfort? And again, it doesn't mean you're making it up. It just means that you're on high alert to everything. And you're talking about that particular brain condition where you are on high alert to things that are causing you anxiety and fear. Well, I think we can begin wrapping this up. And I think that this was a great conversation to have and dive a little bit deeper into some of the things that we spoke about. What other things were on your mind that you wanted to make sure you shared with the audience today about vestibular disorders and about some of the topics we discussed today? I want to give you another opportunity before we end.
Yeah. So, well, thanks. I think we're on the right path. I think we have decent pathways to train healthcare individuals to better understand dizziness. Remember, dizziness can be multifactorial, can come from a lot of different places. So it's hard to train in just one narrow way to cover the gambit of what makes people dizzy. But I think we have appropriate training programs, and we have appropriate specialists. I think that the answer here is an enhanced education and coordination between those specialties. I'm working with the American Neurotology Society to enhance the neurotologist's understanding and knowledge of not only peripheral inner ear disorders, but also a better appreciation for central disorders, cardiac disorders, psychological disorders, musculoskeletal issues for dizziness. So I know that my colleagues in neurology are doing the same thing.
And in physical therapy, they're doing the same thing. Yeah.
Physical therapy doing the same thing. And the
Mhm.
physical therapist is absolutely critical, because in the end, a lot of our patients are going to need a long-term help and readjustment back into life to be able to move within their environment, to move their head, and to coordinate their body within the environment. So in physical therapy, when I started practice, there was no vestibular rehab, there was no balance retraining, there was nothing. And so you had medicine, you had surgery, and then you had, I'm sorry, have a nice day. That's what you had. In the addition of physical therapy to the treatment arm. Okay, so the diagnostic arm needs to be over here. Okay, diagnostic arm needs to be made as accurately as possible, but the treatment arm can be now medicine. Surgery is pretty rare. I mean, there are some things that you operate on in the balance world that help. You can plug an open canal. You can open up the inner ear for Meniere's disease if you wish. There's a few things, but primarily it's medicine and it's rehab. Okay. The key is to get the specialties to work together so you get a good diagnosis, so you get the right medicine and you get the right rehab. If somebody has lost their inner ear altogether and it's gone for some reason, a drug or something, there's no such thing as vestibular rehab. The vestibular system's gone. It's not vestibular rehab, it's balance retraining, substitution therapy. And so it's an educational process, even within our own, to say, oh, now I get it. It's not a cookie cutter, do these exercises, or a cookie cutter, take this medicine. You got to be a lot more precise than that. So we're working on it.
We are working on it.
We are.
I'm hopeful that the Vestibular Disorders Association can expand its ability to bring together this village of healthcare providers who want to have a conversation. It is a joy each time I get to engage with someone outside of physical therapy, talk about vestibular disorders. I think we have a lot to encourage each other on, a lot to share, and I want the vestibular audience across the world to know that we see you, we care about you, and we are working diligently on your behalf. And the Vestibular Disorders Association depends on and needs continued support. And I encourage anyone watching who wants to volunteer, just go to vestibular.org and find out how you can get involved. And we look forward to bringing you another episode of Ask the Experts. And my deepest thanks to Joel Goebel today for joining me and having sort of an opportunity to dive a little deeper into the issues that matter to you. Thank you so much. And until next time, we'll see you later.